Good evening. My name is Susie Hagstrom, and I am the Medical Director of the Medallion Program. My colleagues and I from the Medallion Program are delighted to have you join us tonight for our annual Fall Salon. My hope that tonight's topic will be uplifting. The extremely talented physicians from the relatively new Arizona Cosmetic Center will introduce you to their integrative and collaborative approach to aesthetics. Many may assume that aesthetics exclusively addresses the needs of only those that wish to perfect their appearance. While this opportunity is available, this group of talented specialists are also trained to improve the appearance and function of patients that have been afflicted by a myriad of medical diseases and circumstances that may result in disfigurement. This extraordinary team's skill set provides hope. The structure of the Mayo Cosmetic Center supports the collaborative approach to skillfully and artistically restore both form and function. This evening's event will include an introduction by Mayo Clinic's Cosmetic Center Department Chair, Dr. Michael Hinney. Following his introduction, our three accomplished surgeon presenters will discuss the Cosmetic Center in relation to their individual specialty. Dr. Alika Haas will discuss her role as cosmetic dermatologist. Dr. Brittany Howard will elaborate on her role as a facial plastic surgeon, and Dr. William Casey will round out the presentations with a discussion on his role as plastic and reconstructive surgeon. Following the presentations, we will have a discussion period where our presenters will have the opportunity to answer questions that you, the audience, have submitted ahead of time. Our first presenter tonight is Dr. Michael Hinney. Dr. Michael Hinney is the professor at Mayo Clinic, College of Medicine, chair of the Department of Otolaryngology, head and neck surgery at Mayo Clinic. He received his MD degree at University of Missouri, Kansas City, and completed residency at Mayo Clinic in Rochester, Minnesota. He then completed a fellowship in head and neck, base of skull surgery at Johannes Gutenberg University in Mainz, Germany. His clinical and research activities focus mainly on endoscopic transoral surgery for cancer and endocrine surgery. He's been an active member of multiple societies, and these include American Academy of Otolaryngology Head and Neck Surgery, American College of Surgeons, American Head and Neck Society, Fellow of the American Laryngologic Association, Fellow of the Triologic Society, and Counselor at Large of the American Bronchoesophageological Society or Association. He has been director of more than 20 head and neck surgical educational courses and invented surgical tools and laryngoscopes. He has authored and co-authored over 120 papers in peer-reviewed journals and has edited 3 textbooks. He has delivered over 200 national and international lectures and numerous additional papers. He serves on the editorial board of multiple journals. Ladies and gentlemen, I give you Dr. Hinney.
Thank you, Susie. I wish my mother could have heard that. All of you watching know very well how lucky you are to be a part of the Medallion program. Those physicians are absolutely outstanding. None more than Dr. Hagstrom, who many of you may not know, but I've known Dr. Hagstrom for many, many years. She was originally an anesthesiologist, and she graced the cover of the Top Doctors magazine many years ago, and boy, would I like to have a copy of that to show you right now. So as you probably learned from that long-winded discussion there, I'm not a plastic surgeon. I've found myself in a leadership role and had an opportunity to spearhead or drive the boat to try and get this off the ground, and we have now done that. Many of you may not know that there is more cosmetic surgery in aesthetic surgery being done in the Phoenix, Scottsdale area per capita than any other place in the country. And that includes New York City and Hollywood. So we've put together a center that we think will compete in this space. And how it will compete is because we'll embrace the Mayo model of care, which goes back nearly 150 years now, where we work as a team and we value one another's gifts and skills and treat patients collaboratively. So rather than a center with one skill set or one size fits all approach, we have now multiple departments participating. And you'll hear from three of them. That would be dermatology and facial plastic surgery and general plastic and reconstructive surgery. But we also have physicians and specialists in gynecology and urology participating. We've got vascular surgeons that are available to treat those pesky spider veins or whatnot. So all of the procedures being done, lasering, injectables, fillers, open surgery, and so on, are going to be done by someone that just does that and does it all the time and very well. And we'll freely refer our patients back and forth to get them to the very best person for that problem. Other distinguishing features about this center is it will provide education. There's ample evidence in the medical literature that there's better care provided by teaching hospitals. And we'll have 3 different departments rotating trainees through this center to learn from it. And the other Mayo Shield, of course, is research. And I don't want to steal the thunder from the presentations that are coming momentarily, but we already have clinical trials set up to start in the center. We have a growing regenerative medicine program, and the Department of Regenerative Medicine is partnering with us so that we can bring cutting-edge regenerative technologies into the cosmetic practice. And this is a bit of low-hanging fruit. It's a straightforward way, in my view, that we can take research done in the laboratory and bring it to the bedside to improve care and the lives of our patients. I would love to see regenerative technologies evolve in the center and expand the science so that we can create, for example, a rejuvenated face non-surgically using injectables and stem cell technology. So I'm very excited to have been a part of launching this, and I think it will be a model nationally. There just isn't a center like this. I will not list all of her societies, but our first speaker is Dr. Alika Haas. She did her dermatology residency here at Mayo Clinic in Arizona. She did a cosmetic dermatology fellowship in Los Angeles and was slated to come back to the staff before she left with a program called the Mayo Foundation Scholars. And she'll be up first. Next is Dr. Brittany Howard, who also trained here in the otolaryngology head and neck surgery residency. She then went off and did a cancer fellowship in head and neck cancer and microvascular reconstruction, and then switched gears and did a second fellowship in facial plastic surgery and aesthetics. And she will speak second about her contributions to the center. And finally, Bill Casey, plastic and reconstructive surgeon, also trained at Mayo Clinic. Notice a pattern here. And he's been on staff here for many years, probably not as many as me, but close, and is just simply an outstanding surgeon. So without further ado, I will pass the baton and invite Dr. Haas to come to the podium and get us started. Dr. Haas. Thank you.
Thank you very much, Dr. King, for the introduction. I'm so excited to be with our colleagues in facial plastic surgery and general plastic surgery to introduce our new multidisciplinary cosmetic center. I have been doing cosmetic procedures at Mayo Clinic for about 2.5 years, and it's wonderful to see the growth and success of this clinic. So I will be talking about cosmetic dermatology today. This is a passion of mine. We'll talk about anatomy and facial aging, and then we'll discuss non-invasive cosmetic procedures to address these signs of aging. So cosmetic dermatology. Well, dermatologists are the medical specialists in conditions of the skin, hair, and nails. We diagnose and treat over 3,000 diseases, and most of these diagnoses are made visually. This requires a 4-year residency after medical school, and as Dr. Heaney mentioned, I completed mine here at Mayo Clinic in Arizona.
Can I talk?
Cosmetic dermatologists now often have an additional year of training. This is a fellowship through the American Society of Dermatologic Surgery. During this year, we focus on facial aging and changes in the body that happen with age, and we address these with non-invasive procedures for both medical and cosmetic skin changes. I completed my fellowship with 6 experts in the field in Southern California, where we did solely cosmetic procedures and cosmetic clinical research studies. We treat many different conditions in cosmetic dermatology, so some that are due to aging, like lines and wrinkles, thinning hair, sagging skin, or volume loss, but we also treat scarring, acne scarring, surgical scars, and burn scars, some of which we can collaborate with our surgical colleagues. We treat general skin conditions as well, such as rosacea, melasma, and thinning hair, and we can use medical treatments as well as potentially cosmetic treatments for these. So to understand how we treat these conditions, we must understand a little bit about anatomy and facial aging to understand the targets for treatment. So when we look in the mirror on our birthdays or compare our faces to our parents or our children, we notice that the face is actually aging 3-dimensionally. And this starts deep with bone. We see that on even CT imaging studies, we have found that the orbital rim widens and the maxilla and mandible, the bone of the face, starts to recede posteriorly. And so as this moves, we see that the overlying soft tissue starts to sag, which gives signs of aging. Next, we see that the muscle leads to lines and wrinkles, notably around the eyes and forehead with facial movement, as well as around the mouth. We seem to lose fat in the face as well. This can happen in the temples and the area in front of the ear, but then it can accumulate in the nasolabial folds and the jowls. And then lastly, skin, so arguably my most favorite layer, so we'll spend another slide on this. We see a lot of things happen to the skin with age. The first is environmental and UV damage. With sun exposure and pollution, we see accumulation of free radicals, oxidative stress, and DNA damage. This can lead to pigmentation, visible blood vessels, as well as skin cancers on the face. We also have a reduction in skin cell turnover, leading to a dull and uneven skin tone, as well as textural changes. And then lastly, we lose collagen, elastin, and hyaluronic acid. This leads to more lines and wrinkles, enlarged pores, and dryness. So how do we address these changes? Well, some of the procedures we can do are considered non-invasive. So what is a non-invasive procedure? Well, these are procedures that are not surgical. They're done in the outpatient or office setting, and usually they require only topical or local pain control. There's often minimal break in the skin, and generally speaking, these are thought to have a low downtime. I like to group these into 3 categories, so injectables, lasers, and energy-based devices, and other procedures. We will start with injectables. So first, wrinkle relaxers or neuromodulators. These come by many brand names, Botox probably being the one you've heard the most. And how these work is that they relax the muscles to prevent wrinkles and soften existing wrinkles. The results last about 3 to 6 months, and it's FDA approved for the upper face, but new approvals are pending for the neck or maybe other areas. And we can actually use this off-label for many different conditions, including a wide jawline, maybe gum showing while smiling, downturning, sad mouth corners, increased sweating, and even surgical scars. When we look at the literature, we see that patients are very satisfied with treatment with botulinum toxin for wrinkles and lines. And this study looked at 23 different papers on patient satisfaction and found that there was 65 to 90% satisfaction with this, that it improved self-perceptions, potentially reduced perceived age relative to current age by 5 years, and that possibly there was greater improvement when this was done on multiple areas, so both the frown, forehead together, or even in combination with the lines around the eyes, or in combination with other cosmetic procedures, patients seem to be more satisfied. Dermal fillers are also something that we use as an injectable tool for aging. What these do is that they target volume and deep wrinkles, so that bone and fat loss that we talked about. We have hyaluronic acid fillers. These target certain areas of volume loss, and they are reversible. And then we have fillers that stimulate collagen, and these are longer lasting. In general, the results with fillers last 6 months to 2 years, and we can do these procedures on the face as well as on the body. Looking at patient satisfaction with fillers, this study looked at full face rejuvenation of 77 patients, and they treated multiple areas. And they found that all patients had improvement at 3 weeks, 92.1% still had improvement at 6 months, 79.7% were satisfied or very satisfied with how long the results lasted, and 63% felt a lot or much better than they did before the injection. So it's important to know that we are not doing these procedures to make people look done or to really show that something has changed, but it's just to make people look as good as they feel on the inside. Deoxycholic acid is the last injectable we'll talk about. This is an option for excess fat under the chin. This is only FDA approved in that area, but has been used off-label on other areas, and it works by dissolving the fat permanently. This can take multiple treatment sessions, about 4 to 6 weeks apart, but other than some swelling, this doesn't have too much downtime and does not leave any scarring behind. Looking at lasers and energy-based devices, we have multiple lasers available at both locations at the clinic, and we can treat multiple conditions with these lasers. I think what's most important to understand is that every patient is unique in regards to their skin changes, and therefore specialized devices are needed to target and improve those changes. We'll talk about just a few of these today, given that the time is limited. So redness that we see, this can be rosacea seen on the central face, poikiloderma of Savant, which is a discoloration noted on the sides of the neck, and telangiectasias, which are those broken blood vessels we can see on the face or around the nose. Rosacea in particular is very complex. This can be due to vascular hyperactivity, getting worse with heat, stress, or different foods. It can involve the immune system. It can involve oxidative stress. Definitely sun exposure is a concern with rosacea, and many patients have a genetic predisposition to this. Organisms can also be involved too, so a mite called Demodex, and even the gut flora has been associated with rosacea. When we look at treatment for this, the best treatment is a pulse dye laser. This is a single wavelength device, and this targets hemoglobin in the blood vessels to reduce redness and telangiectasias. With 1 to 3 treatments, we see about 50% improvement, and downtime involves a little bit of swelling and redness for 3 to 7 days. Like any laser, there are risks, but when done in the right hands, this is very, very unlikely. Looking at patient satisfaction with pulse dye laser for rosacea, this study looked at 16 patients, and they asked about symptoms and quality of life after having 2 treatments. And they found that on imaging, the redness improved by 36.2 to 53%. The DLQI score, a score for quality of life, decreased from 7.8 to 1.9, and patient symptoms improved by 57.1%. So very significant improvement for treatment of rosacea. Pigmentation. So pigmentation is very complex. I think especially here in Arizona, we need to differentiate between sun damage that we see in lighter skin types with chronic sun exposure, seeing multiple little brown spots on the face, to patients who have melasma, now a potentially hormonally driven sun-sensitive condition, seen in younger patients with darker skin types and seen as bigger patches of brown spots. It's important to differentiate between these because melasma is very sensitive. This is sensitive to sun, heat, and irritation. And really, actually, for this, a topical treatment is best. That is really important to understand because lasers and chemical peels can actually potentially make this worse if the appropriate settings are not used. Looking at a study that did use a laser, this was done actually out of my fellowship in San Diego. They used a fractionated device. So this uses only a fraction of heat on the skin, and they were able to improve melasma with this. They found that about 12 out of 20 patients had 50% clearance or more, but about half of patients noted that the pigmentation came back 10 months later. So this reminds us that topical treatment is definitely appropriate and important in the setting of melasma, even if we are using laser procedures. When it comes to sun damage or those speckled brown spots on the face, we have so many different devices. We have ones that target pigment specifically, IPL, which is like a flashlight, or pigment-specific lasers that are a specific wavelength to target pigment. We also have non-specific devices. These heat the surface of the skin to push pigment out evenly to give a more even skin tone. And these all work a little bit differently, so it's very important to have a discussion with your physician with these topics and see what would be the best treatment for your skin type. And then lastly, other procedures. We'll just touch on a few of these. Sclerotherapy is a procedure for leg veins. This is FDA approved. It causes a localized control inflammation and fibrosis of the veins and has a short downtime of about 1 week of compression stockings and bruising. And usually we see 50% improvement after a few months when that inflammation has subsided. Regenerative medicine, which is a great topic to talk about right now. We're doing this in many different departments at Mayo Clinic, and we're able to take a patient's blood and spin it in a centrifuge with a specialized tube to collect a portion that is rich in platelets. The platelets have been shown to have growth factors that can heal the skin, stimulate hair growth, and can help with scarring. And so we use this for multiple different reasons when it comes to cosmetics. And then lastly, tumescent liposuction. This is liposuction that's done in the office for small areas using a very dilute lidocaine product to help with pain control and to separate the fat cells for even removal. This removes the fat cells permanently and is really the gold standard for fat removal, with 50% improvement after one treatment. So we've talked about a lot of procedures, and I think it's important to say, like Dr. Heaney mentioned, this is widespread and very popular. So why choose the Mayo Clinic Cosmetic Center? Well, we see that injectables are on the rise. From 2014 to 2018, more than $1 billion was spent on injectables. And we see that, patients are getting this really kind of anywhere. And some people might argue that getting injectables is just like getting your hair and nails done. And I would really argue that it's not. And this is a medical procedure. And it's really important to understand that these procedures should be done in a medical settings. If you see here, a lot of complications can happen when things are potentially not done in a safe manner. You can have a droopy eyelid from Botox. You can have infections, oozing, pain, even skin death and skin damage from fillers. And even infections can be spread by using PRP or platelet-rich plasma from one patient to another patient. So definitely want to consider having these done in a medical setting. And not to scare anybody, but we do know that when these are done appropriately, there is a 95% satisfaction rate with injectables and laser procedures when they are done by a board-certified physician. So to end, we have several goals with our cosmetic center, but these are the goals for cosmetic dermatology. We want to take a comprehensive approach to facial aging. We want to advise patients on safety and efficacy of procedures in their unique clinical setting. We want to combine medical treatments, both topical and oral medications, with these procedures to give the best results. And our goal is always to repair the skin and restore natural features. And now we can even heal the skin using regenerative medicine. Thank you, and I look forward to answering your questions at the end of the session.
Good evening. My name is Dr. Brittany Howard, and I am the facial plastic surgeon currently working with the Cosmetic Center here in Arizona. I can't thank you enough for joining us this evening. It's a pleasure to be here, not only speaking with the Medallion team, but also working with my amazing collaborators and partners here in the Cosmetic Center. These are some of the most wonderful physicians, surgeons, and individuals you ever meet, and so spending an evening with them is exactly why we love working in this space. So tonight I'm going to talk about what my role is as a facial plastic surgeon in general and also here in the Cosmetic Center. The topics that we're going to go over are what on earth is a facial plastic surgeon? Doctors have a lot of different names. You've heard of plastic surgeons, facial plastic surgeons, cosmetic surgeons, aesthetic surgeons. So just at least what do we mean when we say facial plastic surgeon? What are examples of common facial plastic surgeries? And where is regenerative medicine right now in facial aesthetics? And to build on what Dr. Haas has talked to you about with that. So first off, what on earth is a facial plastic surgeon? Well, a facial plastic surgeon is someone who specializes on facial aesthetics and reconstruction of the head and neck only. We don't go any lower, we stop at the collarbones. And that's because that's what our training is for. All of my training, all of a training of a facial plastic surgeon is directed at the head and neck only. So we start in medical school, as with all your physicians, and then we do 5 years of an otolaryngology head and neck surgery residency. So during that time, we do 5 years learning about form, function, and cancer treatment of the head and neck. So this is ears, nose, throat, voice box, and the top of the head too. Then we do a fellowship in facial plastics and reconstructive surgery. During that time, we learn more about facial cosmetic surgery specifically, facial functional surgery, reconstructive surgery, and the research that covers all of that. And this is one of the most enjoyable years of my life, where we spend a lot of time talking about what on earth makes us beautiful and what provides not only beauty but function to us as individuals. The face is something that has a lot of aesthetic features. It's also functional. This is where we express and connect with everyone else in our lives. We speak, we hear, we express through facial emotion, and it is so incredibly important to us. So, what does make us beautiful? Is it structure? Angelina Jolie's gorgeous. But if you look at her, she's not perfect. It doesn't require perfect symmetry to be beautiful. Her nose actually goes one direction, and that philtral column that connects our nose to our lip goes a slightly different direction. She's gorgeous. Is it our skin that makes us beautiful? Dr. Haas certainly can make all of our skins better, but that isn't what defines beauty. Is it having eyelashes? I know I've certainly enjoyed when my eyelashes are as best as they possibly can be. Is it hair, flowing locks that go in the breeze? Is it having the perfect nose? And what on earth is the perfect nose? It doesn't require any of that to be beautiful. Is it having a big shining smile? Is it youth? Are we going to define beauty by saying that you must be young? What on earth is it that makes us beautiful? Across all of these diverse faces and diverse individuals, we can recognize that we are all beautiful. And so facial plastic surgery is not about trying to make any person look like a particular set type. There is no beautiful. It's about making each individual look like the best version of themselves, how they feel inside, and removing anything that distracts away from our best features. So, for me, facial plastic surgery is the art of modifying the facial structure for the purpose of improved form, function, and/or reconstruction. So here in the Aesthetic Center as a facial plastic surgeon, it's my job to take those expert skills that I have and work as a team to ensure that every single individual that comes in through our doors gets unparalleled care from the entire group. Because I might not be the right person, but I have amazing collaborators who may have the skill set that someone needs. And very often it's not as simple as just one of us. But working in this multidisciplinary center, we can engage with each other and make sure, again, that every individual gets the best care, not just the care that I can provide. So, then what are things that I actually do in facial plastic surgery? Let's talk about that. You'll notice throughout these talks that we have a huge amount of overlap between us. When you do general plastic surgery and reconstruction, facial plastic surgery and reconstruction, cosmetic dermatology, we all overlap in many features and we build and collaborate together. So part of what I do is minimally invasive work, like Dr. Haas has been talking about. That's been, our injectables that we do in clinic are, whether they be neuromodulators or fillers to restore volume. It's laser treatments. Although, quite frankly, she spends more time doing some of these than I do. And so I know when I'm going to reach out and say, I think that this is a problem that you can best solve. And then for my component, a lot of it is surgical procedures. This is one of the things I specialize in. So it's rhinoplasties and lid lifts like blepharoplasty, brow lifts and fat grafting, neck lifts and facelifts, and moving tissue on the face, not to change how we look, but to make us the best version of ourselves so that there are no distractors, our distractors are minimized. And this is an example of a patient that I would expect to see for rhinoplasty. She's gorgeous. Look at her. But her nose is a little distracting. She has these big, beautiful eyes that shine out from that wonderful face, and then you get a little distracted by her nose. It's something that when she talks to me, she says it's always been crooked and it doesn't look like my family. And we don't know why or if I had trauma when I was young, but I can't breathe and I don't feel like the best version of myself with a nose that looks like this. So this is something where combining both a component of cosmetic surgery, which is a cosmetic rhinoplasty, with a functional nose surgery so that she can breathe better, we undertake to improve this. Not to make her look like someone else, but just like the version that she believes is the best version of herself. So she gets a straight nose that's less distracting, where you just see those big, beautiful eyes shine out. And she and I preoperatively work to try to decide what is that profile that she identifies with. Something that honors her own facial features, that honors her family and her heritage, her culture and her ethnic identity. And this is for her having slightly stronger dorsum, something that's very straight, honored that. And she is at the end of the day happy, which is the only thing that matters. She breathes better and she feels like she looks like her. So let's talk about some of these other surgeries regarding facial aging surgeries. These are some of the very common things that we get asked about, but they're often terms that are thrown around and people may or may not know exactly what each one is. So I just wanted to take a second to go through them. So blepharoplasty or lid lift is one of the most common things that we get asked about. When we talk about a blepharoplasty, we're really just talking about that skin right above the eyes. So just where you can grab it right above the eyelashes. And as we age, it does have a tendency to come down, lay on our lashes, and become problematic for us, potentially for vision or because we just like the way that it looks. So you can actually take those out, and it's a relatively simple procedure. Historically, we also took out the fat around the eye. We frankly don't do that as much anymore because we realized that when we were taking out fat, we were hollowing people. We're giving them that kind of sunken look that makes you look aged. Whereas if you look at this beautiful woman in this photo, she's younger and she actually does have fullness around her lids. That fullness is youthful. Fat is youthful, even if we don't generally like fat later in our life. So that's a blepharoplasty, but interestingly, you have to remember that's just the skin that hangs across your eyelids, and notice that it doesn't go very far past the corner of the eyes. Because as we age, it's not just our upper lids often. Often it's also that our entire brows come down and they crowd out our eyes. So if you just do a lid lift, you don't get that big open eye that people are seeking, that they remember from their youth. So we always have to assess, is it just the lids? Is a little brow going on too? Because although men may be supposed to have brows that sit right at that kind of bony ridge bone brow bone that we have. Women's really should be up and arched above that. So often to really open up the eyes, we're talking about a lid lift and maybe a little brow lift as well, because that's treating this whole forehead region. And we can hide the scars either further back in the hair, right at the hairline, or even right along the eyebrows to give some lift and opening through this. Now, this is something that's been gaining interest. One of the other features that we age with is that lengthening and elongation of our upper lip. You notice that the smile doesn't show as much as we age often. And what that is we truly do have elongation in that area. So if that becomes severe enough, people ask about, can we bring our lip back up? Can we get a lip lift? And it treats this central component right here above the lip. The scars are hidden right around the nose, and it can be a beautiful, elegant way of reinvigorating the smile. And of course, a neck lift. This is one of the very common things. Unfortunately, gravity does take effect, and our neck comes down along with other things on our body. And we lose that defined angle of our neck. We lose that beautiful jawline that we remember from our youth. And we can tighten and lift the skin and muscles of the neck back up. Now, one of the problems with this is that if you lift everything up in the neck, you have to recognize it kind of heaps up sometimes along our jawline. So it's not uncommon that although we might not think about the aging down here affecting our face, they often needs to be combined with a facelift so that we can truly readdress that jawline and minimize jowls that happen. One thing to be aware of is that a facelift really does stop at about this region that's colored in on this photo. It doesn't address the area right around the mouth. The lines and aging that we get right around the mouth are often best treated with laser, fillers, or neuromodulators like Botox. And so that's often where Dr. Haas and I will end up working together so that we get a full facial rejuvenation. So let's take a look at a patient example. This is one of my beautiful patients who I'm always so grateful is willing to share her photos with us. She's a 63-year-old athlete in these photos. And she's out there doing 100-mile bike rides and just at the top of her form, and she does not feel like her face fits her. And she sits there and says, I feel like it makes me look old. And if we really break down her face, we can find signs of aging in most areas. Her brow is lower. It is hooding her eyes and making her look a little bit more tired around her eyes. She has excess skin on those upper lids. She's got a middle face that's come down. We do certainly see jowls down along the jawline. And when we look at her neck and profile, she has significant aging there. But again, facial plastic surgery and all of the treatments that we do in the Cosmetic Center, whether it be with Dr. Haas or Dr. Casey or one of our other partners, is not meant to make someone look like somebody else. So it's not about the facial aging I see. It's about the facial aging that she sees and that bothers her. And when I ask her, really what bothers her is the jowling and the changes in her neck. The changes around her eyes she sees and she accepts, and they don't define her. So she doesn't need that all treated. This is about finding the right treatment for the person that walks through the door, not something that came out of a textbook and not something that came off a magazine. So we did an in-office facelift with her and neck lift. This is something that is unique to each individual. For some people, the right answer is going to the operating room where someone is completely out under general anesthesia to do one of these procedures. For some people, the right answer is being awake with us in clinic under minimal or moderate sedation. For her, it was being awake with us. And this is her 3-month outcome. She is doing wonderful. She's happy. That's all I care about. She's got a definition of her facial jawline again. Her neck is up. And she feels like she looks like herself. She does not look pulled. She does not look windblown or windswept. And everyone just keeps asking her, what'd you do? But not because they know what she did. And that's really our definition of success, because she's happy. So now it's been a couple years since we did this, and now her eyes do bother her. So she and I are actually gearing up now to do her brows and her eyelids, because aging is the most chronic disease we'll ever treat. There is no medication for it. There is no cure. And the moment you treat it, it's back there the next day. So with that, we follow along, and now this is time. And now she's ready for that. And we can address the other areas of aging. So, regenerative medicine and facial aesthetics. What's the current status and what are our future directions, especially here at the Multidisciplinary Cosmetic Center? This is how Mayo defines regenerative medicine. It is anything that enhances healing, modifies healing, restores function, or counteracts the effects of aging or other process to return an individual to an earlier status of function or aesthetic. So this is everything that we're doing at the Cosmetic Center. And it is something that this is no longer about growing ears on mice. This is about applying the recent scientific advances to the individuals that walk in through our doors. So current offerings at the Aesthetic Center that use regenerative techniques include many of our laser therapies. We have data that many of these laser therapies actually do cause change in gene expressions in the skin and reset them back to earlier time points. Fat grafting with stem cells is something that we do, and this provides a restoration of volume and even improvement in the overlying skin. And then platelet-rich plasma, Dr. Haas has so much experience doing this for hair restoration, scar management, volume restoration. And those are all things that we're doing today. Future directions are, of course, many of the things that we're most excited about. So by the year's end, I firmly believe that we will have our anti-aging clinical trials running in the Cosmetic Center. This will include not only trials for injectables, but also clinical trials for active skincare, where we actually have agents in the topicals that we will be working to see if their effects on the aging process. And we also are currently using 3D scanning to help us with precise surgical modeling and precision, especially in our reconstructive cases, where restoring someone back to their true form and function is our ultimate goal. And one of the things that's really making all of this possible and that I'm ecstatic about is that we are adding a new facial plastic surgeon to the team coming in February 2022. She's coming with close to 15 years experience in this space. She's nationally and internationally renowned for her anti-aging work, injectables, surgery, and working as a clinical researcher. So we can't wait to officially share the name and start date for her, but please be on the lookout. And we're very excited that that also means starting in February 2022 that we will have significantly increased access and availability for caring for all of our wonderful individuals that trust us with their care. So with that, I just want to say thank you so much for spending some of your evening listening to these talks and the amazing collaborators that I get to work with every day.
Right. This is a tough act to follow, but thank you, Dr. Haas. Thank you, Dr. Howard. Thank you, Dr. Hinney. Thank you to all the team, including Dr. Hagstrom, who put this together, for allowing us to be part of this. I'm really excited to have a multidisciplinary cosmetic surgery center here. It's something that I think Mayo can do and do very well. I think that I may not be the best person for a certain patient's needs, but we do have the clinical skill set and the people that can meet the needs of every patient out there. And I'm really excited to be part of this. I am a general plastic surgeon here. I'm always interested in when people ask, what is plastic surgery? My typical answer is, what is plastic surgery not? If you look at how broad our specialty is, it includes hand surgery, craniofacial surgery such as cleft lips and palates, burns, cancer reconstruction, pretty much everything out there. But what we are known for most is aesthetic plastic surgery. And that's something that the public sees us at, and that's something we do here. It is interesting, a lot of people think that we get overshadowed by the reconstructive work that we do here, but we do pretty much the entire bandwidth of aesthetic plastic surgery. I want to go through some of the things that we do here in our group. We do skincare, but we also collaborate with our esthetician, Anna, who is fantastic, our other colleagues in the Cosmetic Center. But we do fillers, Botox, laser treatments, and pretty much the whole spectrum of non-invasive techniques. But what I want to spend the most time on is some of the surgical procedures that we do here, because that's really what defines us, and that's what I enjoy probably the most. We've talked a lot about kind of the natural sequence of aging. But I think we've gotten away from the take it away techniques of cosmetic surgery, the tighten everything as much as you can. So we've gotten away from the Michael Jackson noses, the Joan Rivers facelifts, and we're trying not to just tighten everything. We're really trying to restore things to the way they used to be. And I think both Dr. Howard and Dr. Haas talked a lot about some of these aging things that happen over the years. So we see that skin stretches, we get wrinkles, we lose volume, and we really want to restore all those things. But not all descent and gravity effects are always ugly, and I just want to put this up there as a reminder that some things are still beautiful, even saggy. But we can definitely see what happens over time. We see that the face does sag, gravity wins, it is a law. We see that wrinkles start to happen. There's also these areas where there's really tight attachments of the skin to the underlying facial skeleton. And because of that, when skin sags or falls, we start to notice that there's some places where it deepens, these marionette lines, these nasolabial folds, these areas around our eyes that form these what we call tear troughs or nasojugal folds. But we really want to not only put those things back where they were, but also restore the volume that's been lost. And that's where some of these comprehensive treatments, such as fat grafting, the laser treatments around the mouth, some of the fillers, in combination with things like facelifts, can be so beneficial for patients. We also want to restore the normal proportions. We want to keep things in harmony. We don't want to do one thing and have it magnify a problem somewhere else. We really want to restore harmony to the entire face. We also need to know what's important to a patient, and I think that's what's critical during the initial consultation, because there are some patients that may embrace their wrinkles. They may be completely happy with them. Our goal is to really define what bothers a patient so that we can really address them, because ultimately they're the ones that need to be happy. As I mentioned, we do lose some volume in the face over time. There's a lot of compartments of fat within the face, and our goal is to restore that. And that's where some of these regenerative techniques, such as fat grafting and stem cells and stuff, can be very beneficial to restore the volume in the face. We also talked a little bit about things like these platysmal bands. I won't spend as much time because I think Dr. Howard spent a tremendous amount of time that was very beneficial for you all, talking about some of the rejuvenation of the neck. But typically, the neck is part of a facelift. As we mentioned, the whole goal is to kind of redrape the skin, tighten the skin, eliminate wrinkles, and restore some of the volume. I do this under a general anesthetic. I know Dr. Howard does this under local with some form of sedation. My father was a plastic surgeon for 31 years, and he did a lot of these under local anesthetic with some sedation. It's a very effective technique. That's not something I'm super comfortable with, so the majority of mine are done under a general anesthetic. We do need to be aware of some things that may make patients not quite as good a candidate, things like blood thinners, high blood pressure, things that may put them at risk for having problems with bleeding or other things. These are some of the typical scars that you'll see with a facelift. We really want to make sure that we avoid some of these things like this upper right where you see these stair steps in the hairline. So we really try to do things to hide these so that it's optimal. Unfortunately, scars are always there, but I always say plastic surgeons make good scars because we operate on the right places. The face heals remarkably well and tends to scar really well. I like this picture because it shows how the only real part of the scar that you'll end up seeing is in front of the ear, just above the earlobe, and in a woman you can actually pull the middle part behind this part of the ear called the tragus, which is really nice because you can hide that part of the scar. You don't want to do that in a gentleman because then you're going to be pulling the beard into the ear and it's going to drive them nuts. But these are some of the results that you can start to get. You can see that you've redraped the skin, eliminated some of the wrinkles, restored some of the volume, and typically these patients are some of the happier ones that we have. Again, I won't belabor the point because I think Dr. Howard did such a nice job of this already, but you can see that all of these areas tend to be a lot more youthful just by doing a facelift alone. Well, I'll spend a little bit of time on a brow lift, and brow lifts are very important because we always forget, as Dr. Howard was saying, how the people come in saying that they want their eyes done. They say that they look tired, they say that they don't look as refreshed, and they usually come in and say, I want my Blepharoplasty, and they do this, and they try to hold their brow up. And what happens is the brow starts to fall over time. And if we only do the lids, the problem's going to be is we're going to lose that natural kind of stimulus that the body's telling, because if there's any blockage of vision from that extra eyelid skin, our body's natural response is to hold our eyebrows up to unload the weight off of our eyes. And once we just take the eyelid skin away, our brows are going to settle more. So we usually like to do a brow lift in conjunction with a blepharoplasty if we find that the brow is needed as well. This is somebody that certainly you would not want to do just a blepharoplasty or an eye lift alone. You would want to do their brow because that's the main feature that's causing problems. So there's different ways to do that. You can go in front of the hairline, you can go in the hairline, you can do it endoscopically, and as Dr. Howard said, we can also do some at the brow itself, depending on the degree of deformity and also how tall the hairline is from the brow, because the longer it is, we don't want to unnaturally pull the hair back even further and make it look like they have a taller forehead. So for somebody like this that has a tall forehead, we'll usually do it at the front of the hairline, right at the edge, because by doing that, we can actually reduce that distance and make things look more youthful while still lifting the brow. There is another way that you can do it endoscopically. I always call this the carpet tacker technique, and what I mean by that is if you think about the little nails that hold our carpet in place, these are little devices that stay in and dissolve after about 6 months, and we bring the skin up and deploy this onto these little 3mm tacks that hold the skin in place until it's had time to scar where it's needed. And then it's done through much smaller incisions, so much less likelihood that you're going to injure any nerves that may make you lose some sensation to the scalp, which a brow lift can do with the open approach. So you can see, as Dr. Howard was mentioning too, in a lady, you typically want to have the brow above the bone at the top of the eye, so above the what we call the supraorbital rim. So that's the natural appearance, and that's what's going to give people that wider eye look, that more refreshed look, and that's often done in conjunction with the blepharoplasty. The blepharoplasty is one of my favorite operations. It's nice because that's where people tend to be looking at somebody. That's where I think it's the most bang for the buck, because it's a relatively quick recovery. There's a scar in the upper lid that's where a crease normally is to begin with. So the scar hides very nicely. The recovery is fairly fast, and it makes the biggest difference long term. So this is typically what we want to take out. We want to take that tissue out where the crease normally is and then tighten up that skin. As Dr. Howard was mentioning, we don't want to over resect any of the fat because we don't want that hollowed look. We don't want that skeletonized look. If you look at children, they have very full eyes. It's just that the fat is in the right place. There are some times on the lower lids that we'll think about redraping the fat across the rim of the eye socket, because that actually helps to soften that transition to what we call the tear trough into the cheek and restore that natural transition and harmony between the upper third of the face and the middle third. And this is what I was talking about, how it just gives you more of a refreshed look. You see that the scar is in a hidden location in that upper lid crease, and it definitely makes them look like they're less tired and more youthful. Again, some other examples. I won't belabor the point because I think my other colleagues have shown a lot of really nice results with this. I'll spend a little bit more time on some of the breast, chest, and body contouring procedures because I do think that is unique to the general plastic surgery field, which we do. With breast surgery, we can make them bigger, we can make them smaller, we can give them a different shape, and that is to reduce some of the droop, meaning like a mastopexy or in reconstruction, or we can do both where we make them bigger and a different shape, and that's where you start talking about breast lifts combined with an augmentation or an enhancement. Breast reductions are probably my favorite operation. These patients are by far my happiest patients. They will gladly accept the scars that come along with the breast reduction because it takes all of the weight off of their shoulders, their neck, all that difficulty in getting their clothes to fit right, bras to fit right. And actually, if you look at their physical activity, it tends to, their athletic performance tends to improve just with the reduction in breast size. These are some patients that are some of the typical ones that we'll see where they have a significant amount of droop over time, and we can restore that more youthful shape and bring that breast back up onto the chest. Breast lift patients don't always necessarily want to exchange scars for a better shape, and that's the difference, I think, between a breast reduction and a breast lift, which technically is the exact same operation. This is actually a police officer that we did, and you can imagine what it would be like for her to get in a bulletproof vest every day or try to run after perpetrators or other people with breasts that size. And her performance in the police academy improved just with the breast reduction alone. I think just from her overall well-being, her neck pain, her shoulder pain, all of that is almost instantly gone. It's one of the best operations out there. It's interesting because with breast reductions, it actually does reduce the risk of developing future breast cancer. And it's probably because we're removing some of the breast cells that could potentially be prone to developing breast cancer later. Breast augmentation, I want to spend a little bit of time out there because breast implants are probably one of the most controversial and it's interesting, probably most studied medical devices out there, but also one of the most critiqued or criticized medical devices out there. We'll talk a little bit about some of the implant issues out there. Interestingly, the first breast augmentation was done by taking a lipoma, a fatty tumor, from somebody's back and placing it in the breast in 1895. But breast implants really didn't come around until the early 1960s, and this was the basis for the movie Breast Men. But Cronin and Giroux developed the first breast prosthesis, and then Dow Corning took over. The only problem with that is in the 1980s, a lot of people were starting to say that breast implants were causing connective tissue diseases like rheumatoid arthritis and lupus and things like that. That led to the media getting a hold of this, especially the Connie Chung interview. And then once lawyers became involved, that led to the 1992 moratorium on breast implant use. It's interesting because my dad was a plastic surgeon at that time, and it never made sense to him because they allowed us to continue to use them for reconstruction, but not for cosmetic use. So my question is, if they're bad, shouldn't they be bad for everybody? Since that time, again, they've probably been one of the most studied medical devices out there. If you looked at the Mayo Clinic study done in 1994, they looked at 749 women that had breast implants, and 5 of them had connective tissue disorders. They also looked at 1,498 women that did not have breast implants, and 10 of them did. So the exact same percentage. And if you go down to Scottsdale Fashion Square alone, you'll see enough women running around with breast implants that some of them are going to have some of these connective tissue problems. Harvard also did a study in 1995 that looked at almost 88,000 women. And if you looked at women that had breast implants, their relative risk of having a connective tissue disorder was 0.3. That means that there were 70% less women that had connective tissue disorders than women that did have or that did not have breast implants. So because of what's called the adjunct studies, these are the studies that were mandated by the FDA in women that had breast implants between 1992 and 2006, ultimately there was enough data that the FDA re-released silicone implants for general use, which was great for us because I do believe that they're a better implant than saline implants, and I do believe that they are safe. The one thing that is a true problem with breast implants, I have no doubt in my mind, is something called breast implant-associated anaplastic large cell lymphoma. It is a white blood cell cancer. It is linked to implants. It's kind of in this in-between some of these really benign forms of lymphoma and these very aggressive, life-threatening, and deadly forms of lymphoma. So it's somewhere in between. It presents as a fluid collection at least 1 year after the breast implants were placed, and it's not subtle. So if you look at this lady's left breast, it is markedly larger than her right, and that happened fairly quickly. It happens in both reconstructive cases and cosmetic cases. It happens with both silicone and saline implants. Scott Spear, who was on the FDA hearings of this in 2006 when silicone implants were re-released, said that the number one thing for us to do is find the data and to be scientists and look at things objectively. And I think our job as physicians, our job as Mayo Clinic is to make sure that we're doing the right things for patients and going with the science. And the nice thing about breast implants is what we have found is textured implants are what seems to be the problem. There has never been a case that a patient has purely had smooth implants that has subsequently developed anaplastic large cell lymphoma. There have been cases where patients have had both smooth implants and textured implants, or just textured implants. But textured implants tend to be the problem, which is why they have been recalled and actually been taken off the market. The last time that I looked at the numbers, there were 573 cases were reported worldwide. 481 were one particular implant company, but every implant company has had one. There have been deaths because of this. Most of the time it is treatable if it is caught early. It's a broad range of symptoms that people come up with. But there's never been a case with smooth implants, which is why I think that they are safe. And that is all that we use here is smooth round silicone implants. Breast implant illness is another one that's out there. You'll hear a lot about it in Facebook groups and the media and the public. It's a really broad range of symptoms that patients present with. In March 2019, the FDA held a 2-day conference looking at a lot of the data that went along with this. And this led to a statement in July of 2019 where the FDA states that there is no definitive link between breast implants and breast implant-associated illnesses. That does not mean that we're done looking at this. That does not mean that we're going to stop trying to figure out what's going on. They continue to be studied, and I do have some patients that have come in with breast implant illnesses that they have claimed, and I've taken their implants out, and they do feel better. So I'm not going to discount that, and if somebody wants to come in here for that, I'm happy to help them out. Breast implants can range anything from normal, just small enhancements, still a natural look, to clearly the augmented look, which some people are going for. One of the problems with them is implants can become a little bit more firm over time as the scar tissue tightens around them. They can be put in through a various number of different incisions. Some people will put them in through the belly button, but that does void the warranty, and you cannot put silicone implants in that way, only saline ones. I traditionally do the inframammary approach, or the one at the bottom crease of the breast, because I think it's the least noticeable. I don't like the ones that sit around the areola, although you'll see plenty of people that have those. I just think that that puts a scar right in the center of the breast, and that's one that's more visible. But it's one of the only ways that you can start to get a little bit more of this upper pole volume, this more fullness, this more youthful appearance to the breast, is with breast implants. It's really hard to do that just with their own tissue or with lifts. It doesn't mean that these are a one-and-done thing. About 1 in 4 people need to have some kind of reoperation over their lifetime or even in the first 4 years. That scar tissue that forms, that tightens around implants, happens in about 1 of 8 people, and that can get to the point where the breast feels a little bit more firm or unnatural or even a little bit more rounded or distorted. Implants have a rupture rate of about 1% per year per implant. If they are ruptured, we do recommend having them exchanged. Interestingly, we talked about the anaplastic large cell lymphoma, a white blood cell cancer linked to textured implants, but implants themselves have actually been shown to reduce the incidence of breast cancer per se, the real breast run-of-the-mill type of breast cancer. And we think that that's probably because the pressure that the breast implant places causes some atrophy or involution of the breast, leading to less breast cells in there. And again, this is another one showing that breast implants do seem to have a lower incidence of breast cancer in that patient population. There are some precautions with it. There are some things that we want to make sure that we're addressing before a patient comes in and actually has surgery that we want to talk about during the initial consultation. A breast lift combined with implants is great. It's one of the few things that can bring the breast back up and not magnify any kind of droop that they already have, and also give that upper pole volume that patients are oftentimes looking for. But there's no way with a breast lift alone that you're going to get this fullness in that upper half of the breast that you would without an implant. Spent a little bit of time talking about some body contouring techniques such as abdominoplasties, thigh lifts, brachioplasties, and liposuction itself. So with abdominoplasties, we're usually taking the lower part of the abdominal skin. It does put a pretty sizable scar down in the pant line, but it's one that hides very well, and it's one that doesn't seem to cause patients very many problems. I try to avoid this up and down incision and just do the side-to-side incision as well as the one that goes around the belly button. There's a wide variety depending on the needs of the patient. Does it go all the way around? The nice ones for people that have had massive weight loss or gastric bypass and lost a lot of weight is this circumferential belt lipectomy, or what we call a lower body lift. That's one of the ones that can really address everything all the way around. A little bit longer recovery with the body lift or the belt lipectomy, where it goes all the way around, because you can't really lean forward to take the tension off like you can with an abdominoplasty alone, a tummy tuck alone, because you'd be stretching the back, and you can't straighten up as much because you'd be stretching the front. But these are some of the results that you can get. I do think that it makes a really nice difference in some patients, sometimes even combined with liposuction. again, it's one of the few things that can provide an almost instant cure for some of these problematic areas that patients tend to present with. We see people, especially that have had a few kids, that come in that have a lot of redundancy right around the belly button. It's one of the few ways that you can get rid of that. There's no kind of weight loss technique, no skin tightening creams or anything else that's really going to do this. And this is where surgery really comes in handy. Liposuction is great. It's not really a weight loss technique, but it is a really nice way to contour things. It's a really nice way to help reduce some of those problematic areas. For example, in men, kind of right around the belly. Women tend to be a little bit around the thighs, but it's a really nice way to go, and it's a little bit quicker recovery than some of these bigger surgical procedures. And these are some of the results that you can get. Again, some targeted areas that people find problematic. I'm not a huge fan of brachioplasties, but if somebody has extra skin in their upper arms, it's a nice way to get rid of it. It's one of the few ways that you can get rid of it. The thing I don't like is the scars tend to be a little bit more problematic. They are prone to stretching or thickening over time, and some people can get some numbness around the elbow, which can be a little bit problematic. This is one of the ones I'll show you a little bit more as far as these belt lipectomies and thigh lifts that can, again, take care of some of these problem areas. They do require general anesthetic. It does require some recovery of up to about 6 weeks. But again, it's the only way to really address some of these areas that are really troublesome. And this is one of the final ones with this kind of lower body lift area where we can really address everything circumferentially around the torso to make a nice difference in all aspects. So again, with body contouring, we got to be careful, especially with liposuction alone. It is not a weight loss technique. It helps to reshape things and redistributes volume and gets rid of that extra volume. Scars are always going to be there. That's the nice thing about liposuction is it minimizes scarring. Most of these can be done as an outpatient. Some of the bigger body lifts and abdominoplasties, especially in some of the older people, we do tend to keep overnight. We are very diligent about following up to make sure that patients don't have complications. That is one of the benefits of being here at Mayo Clinic. I think we do have the resources to take care of anything that comes that a patient may present with. So we are here to take care of you. We're here to take care of anything that comes up. Again, I may not be the best person, but with our multidisciplinary team, with everything from facial plastics to dermatology to urology to vascular surgery with the spider veins, we have somebody that can take care of pretty much anything that a patient presents with. And we're here to stick with you to make sure that you get the best result possible. So what I can say about us, we do offer the full range of cosmetic surgery here. I'm excited to be part of the Cosmetic Surgery Center. All of us are well-trained surgeons, dermatologists, practitioners, and all of us are supported by the clinic. I think the thing that distinguishes us is the fact that it is multidisciplinary. I do think that we have some of the research and technology to put us at the forefront of cosmetic surgery. I think we provide safe and effective care. I think we really provide every need that a patient presents with. And we oftentimes state it, but I do think that it's something that we live by here. And the best interest of the patient is the interest that we should consider, and that's what the Mayo Clinic stands for. And our goal is to provide every bit of care, whether it be anything from a cancer reconstruction to cosmetic surgery. We are here for the full gamut. So I want to say thank you, and I appreciate your time and spending your night with us.
Let's start with Dr. Hinney. Dr. Hinney, one of our questions presented is, how does one actually get an appointment? Is there one line or appointment number that would direct one to one of the various surgeons or consultations?
There is one line.
Okay.
And don't make me quote the number.
Okay. All right. So if I wanted surgery versus a dermatology consultation, that would be the same number.
Same
Is that
number.
Correct?
You can call in and describe what your needs are. If you want to see a specific surgeon or physician, that would be certainly set up right away. And if you just wanted a chat with somebody that does rhinoplasty, then that appointment would be scheduled with whomever is first available that does that kind of work.
Okay. So you describe a cosmetic center. Does that mean there is a freestanding building where you can be directed to and have your treatments? Or
I'll take that one too.
Okay.
Sadly, no. I would love to see someday a freestanding building for the Medallion program in which the Cosmetic Surgery Center thrives. And then these wonderful Medallion physicians could take care of every need that you might have. One-stop shopping, that would be perfect. Right now we have a center that is sort of the brain of the cosmetic center, but there's too many people actually participating that not everybody can physically fit in the center all the time. So there will and may be appointments with various specialists that wouldn't actually be physically in the center but on the campus.
are most of them on the Phoenix campus or are some on Shea?
Some is on Shea.
Okay.
I would,
Located at Shea, about 60% of the time, and maybe about 40% at the other campus.
Okay, so I could request to be seen at one campus versus another for dermatology. Okay. All right, thank you.
do you know the number?
Yes, so there is actually that central number is 480-342-2500. So it's just like the main Mayo number, but 25 instead of 2000 for the last four.
Okay.
And that goes straight to Callan, who's our wonderful cosmetics coordinator. And so it's a single person that is consistently answering. And she's familiar with all of us and all of our different areas of expertise. And so she's very, very capable to have a free conversation with someone and kind of walk through what it is they're concerned about and where they would most likely get the most specific care, where someone else doesn't have to make that guess.
Okay, so Dr. Howard, what if I have no idea where to start? So how can I make a consult and say, I'm an open book, please, can I be scheduled with somebody? Would it be with any of the surgeons or would it be with the cosmetic dermatologist? How would you?
That's Callan's wonderful because she'll sit there and kind of try to piece through a little bit even of like, what is your history? If you had to rank your concerns from 1 to 5, what would they be? And talk to you honestly about what the different skill sets are and try to find the right match. And it's not 100%, but that way you're not completely guessing and you've got the best chance of getting the most comprehensive care immediately instead of having to do different appointments with different people.
So is that visit with Callan over the phone or face-to-face?
Phone, and she responds fabulously on the patient portal too, so
Okay.
she gets right back to people.
Okay.
And a great place to start is with Anna, the esthetician.
Yes.
Oh, okay. So is Anna in the cosmetic center?
Every day.
Okay. So I could go in, make an appointment for skincare or products, right?
Yes.
But do I need Dr. Haas to advise Anna on what to do? How do you interface with Anna?
That's a great question. So Anna and I have worked together to discuss some of the conditions that need to see a dermatologist. So rosacea, melasma, maybe certain types of skin lesions. She's very familiar with her boundaries and what she can do and what we can do in dermatology to help patients. So she sends patients over to me all the time, and she takes care of a lot of patients too, offering skincare and superficial skin procedures that can help them. And I think she also can help, seeing some of the skin changes that could require surgery. If it's, loose skin, eyelids, brows, joweling. I think she has sent some patients to Dr. Howard and Dr. Casey for some of those conditions as well.
So what if I just know I need to bypass Anna and I need, I've had melasma or problems with previous skincare. Can I just request to see you directly?
Of course, yes.
Okay.
A patient can request to see any physician directly.
Okay. All right. Along your expertise, do you have several skin products or skin lines that you recommend for the average patient, or how do you?
That's a good question. So we do sell skincare products in the center. We sell SkinCeuticals, which is a medical grade evidence-based product line. And then we also sell Elastin, which is another product line that has done a lot of research on their skincare products. When it comes to skincare, you know, some patients think that more is better, and that's really not the case. First and foremost, everybody needs sunscreen. If somebody asked me what my top 3 skincare products would be, all 3 of them would be sunscreen. You want to be using that during the day on the way to work, maybe on your way home from work if you're leaving mid-afternoon, and on the weekends when you're doing outdoor activities. There's really no role for a laser procedure if we can't protect ourselves from the sun, because we want to protect that investment first and foremost. If we're going to add other things, I hope I'm not rambling, but if we're going to add other things, an antioxidant in the morning to even boost your sunscreen more would be first, followed by a retinol at night that can help with discoloration, collagen production, glow, and smoothness of the skin. So those 3, sunscreen, antioxidant, and a retinol.
So is an antioxidant a vitamin C serum? Is that
Yes.
what you're referring to?
Yes, a vitamin C serum, ideally one that has been studied well, as vitamin C is very unstable and can be oxidized. It's often combined with vitamin E and ferulic acid to make it a little bit more stable and more active in the skin.
Okay, thank you. Now, do each of you also offer the laser treatments? How does all the surgeons, all the players here do laser?
We do. I know Dr. Casey and I both use lasers that are in the Cosmetic Center here on the Phoenix campus. And it's something that we love offering to our patients, be it before surgery, after surgery, or sometimes instead of surgery. It just depends on what the concerns are. However, I will say that Dr. Haas has access to a wider range of lasers than I do down in the Cosmetic Center, because she does have unique equipment that is not only just with us on the Phoenix campus, but also out on Shea in the Scottsdale campus. So those are some of the reasons why, even though, at least for myself, I also do laser, I know that Dr. Casey does quite a bit, that there's still some times where we've got, you know, Dr. Haas on the phone telling her, gosh, we've got someone that really needs to come out to you at Shea, because she's got the special tools out there to deliver the care that they need.
So I'm going to pick on you again, Dr. Haas.
Yeah.
So what special tools do you have that they don't? So in terms of the laser, what unique?
Yes, so on the Shea campus, we have our pulse dye laser, which I talked about for redness. We have a Fraxel device, that's the fractionated device that I talked about for melasma. We have a milder version of that called Clear and Brilliant. I have a Pico-Way laser that's great for brown spots and tattoos. There's something actually similar at the Cosmetic Center called Revlight. There's so many different lasers out there for so many different things. And so I think starting with a consult really with any of the physicians to help determine what laser you need is the first step. And then patients can be directed to either location.
That's probably the key, because people love the buzzword laser.
Yes.
The downside to that is different lasers treat different conditions, and the right laser needs to be applied to the right condition for the optimal results. And I know Dr. Rebecca and I, my partner, do laser work, but again, the spectrum of conditions that we treat is much more narrow than, say, for Dr. Haas. So we try to stick just within our lane and stick to the stuff that works and we feel comfortable with. But that's what I was saying. Maybe I'm not the right person, but combine all of the forces, and now we have the needs of every patient that we can meet.
So what I'm hearing is that you all will pick up the phone and discuss cases with one another to figure out what the best fit is.
All the time, and even in the other direction. You know, as a dermatologist, I know my limits of what I can do with non-invasive procedures. And so I talk to our colleagues in facial plastics, general plastic surgery, all the time for patients who aren't going to get the results with Botox or filler or laser. They really need a surgical procedure for loose skin or brow lift. Sometimes, you know, it's not up to me to even say, do they need eyelid surgery or brow lift, right? That is Dr. Howard and Dr. Casey's expertise, so I will send them right over for that consultation.
Or even work in concert with each other, so that
This is the real goal.
add the two together and you get the real benefits.
Definitely.
And give me an example of what you're referring to.
I think Dr. Howard was mentioning it when she was talking about facelifts, but then facelifts don't pass what we call the nasolabial folds, this area here. It doesn't address the mouth. It doesn't address the lips, those little fine up and down wrinkles that sit around the lips, the descent of the lip or elongation of the upper lip. So once you get into those, some of the lasers can be helpful, or the fillers, or the Botox or neuromodulatory medications that can be applied, and you put the two together, it's great.
And then another example is, Dr. Haas and I share a patient that unfortunately had a severe burn across her face and neck. And so she worked extensively with Dr. Haas, modulating that scar with lasers. She had an amazing result compared to where she was a year ago, but ultimately she continued to have a very significant scar band that was tethering and tightening her neck, and it limited her from having full range of motion. So at that point, Dr. Casey and I would step in, and we did, a release of that in a surgery that actually walked out that scar and gave her additional length. And so now she's got complete range of motion again in her neck, and she's got this increased comfort. And it's that type of collaboration that is really rewarding, not only because of the care it provides to the individuals, but because it gives us great joy as well to work with wonderful collaborators.
So the pressure is not on the patient to figure out where to start.
No.
Because if they start one place, you all are so familiar with your different skill sets that you will make sure they end up with the right constellation of people. to work on them.
Precisely.
Okay.
The other thing that's, I think, unique here is kind of the business model of Mayo, and that's we're employees of Mayo Clinic. We're people that are trying to give the best advice to patients, not trying to sell anything. We're not trying to say, you need this. It's, again, I'm going to go back to whatever a patient presents, what their desire is, what their goal is, what bothers them most, that's what we're going to work on, if we also feel it's the right thing. We've got to make sure that we're counseling them on what could help or what also we're starting with, but we're not here to sell surgery either if it's not the right thing, or if there's a better option, for example.
Mm-hmm. Do you ever have patients that had a failed surgery elsewhere come and say, I want a revision, and how do you feel about addressing, I'm going to use the term botched plastic surgery. Do you get involved in those sorts of cases?
We definitely
I've never
do.
been
on the show, fortunately, so that's good news number one.
But is that
Of course, this is part of it, and I'm sure
Okay.
all of the physicians have.
okay? All right, good. Let me see. What else do I have here? The regenerative medicine and different products. So somebody asked if the fat transplant is actually a version of that. Is there in some way, if you take your fat from your belly and let's say fill in your temples, does that actually have similar benefit as stem cell injections or treatments? Or can you explain that a little bit?
The fat transfers with stem cells are very much along a spectrum with traditional fat grafting. I think one of the things to be aware of is that right now in the U.S., modifying stem cells and then reimplanting them is outside of what the FDA allows. And so that's not currently an allowed therapy in the U.S. So what we do have that's allowed...
Even though it's your own tissue.
Even though it's your own tissue. And so that you can do that there are good studies coming out of other countries, but that's not something that's currently allowed in the U.S. And so what we do have is good data and good basic science that tells us that when we do these fat grafting, that different components of the fat have different populations of stem cell densities, and that those stem cells have a tendency towards maturation into specific types of cells. And so it's not so much that it's wildly different than the kind of old-fashioned fat transplant as it's a refinement of that, where we know the stem cell populations we're selecting out of that traditional fat graft and focusing in and using that in the transfer so that we are more likely to get the results we want.
That part's a really important point about
Yeah.
the modifications. That's outside of the realm of what we're allowed, because
Okay.
then it would be considered a drug, and FDA then has jurisdiction over that. But at the same time, we do plenty of fat grafting in multiple areas of the body, and we do see a lot of the beneficial effects, especially you see these patients that have had radiation changes and all of a sudden some of the whether it be the hormone, whatever's in that entire unit that we're putting in there, it's going to have some benefit to that tissue. It's going to start to restore better blood flow, reduce inflammation, that kind of thing. So we do see that, and that applies even for the cosmetic realm too.
So what I'm hearing is that you transfer the fat, but we just know that there's stem cells in there. You haven't modified them, but we just know that it is a version, but it has not modified. You haven't spun it down or...
We do spin it down.
Oh, okay.
We do spin it down, and so we actually spin it in a centrifuge, and we get layers. And then, for example, the fat that we transfer into a nose is not technically the same fraction that we would choose if we were, or for me at least, that I would choose if I was transferring into cheeks or temples, because I actually want different cells with different cell types and different characteristics behind it. So we go as close as we can within the current safe realms of science.
Okay, I'm definitely deviating off of the patient questions here, but why would I do Juvederm or a filler? You know, that you walk into the office, somebody pulls a jar and says, I want to, say I have a filler in my cheeks. Why would I do that versus do fat grafting or transfer? What?
There's a few benefits to Juvederm or Restylane or one of those other fillers. And the main one is that it's reversible. We can put it in. If you don't like it, we have an enzyme that also comes in a vial that we can inject and just get rid of it. I think that's the reason why patients have gone more towards Juvederm and Restylane and away from fat. But it doesn't mean that fat isn't a good option. It just needs to be done properly, I would say. And I would defer to you for more.
That's very much how I feel.
That.
I'm not... this is a big choice whenever we change something about ourselves, and doing something that's not reversible is certainly much more dangerous for our happiness later than doing something that is reversible. So I really want to hear typically from someone that they've done, the Juvederm or the Restylane before, and that they're really sure that this is an outcome they want and they're interested in a more permanent option. And the other thing is that I often hear, I'm sure you do as well, Dr. Casey, of I'm interested in fat grafting because I don't want to keep having to do these procedures. And no surgery comes with a guarantee of one and done. And fat grafting is very much that as well. We know that when we do fat grafting, we only have survival of our graft somewhere between about 30 to 50, even sometimes losing 80% of a graft. And so you still have to be emotionally ready to potentially go through multiple procedures to have the result you want. And so when people are looking for it to be a quicker, permanent fix, it's a lot of discussion and education to make sure that what we're all talking about is realistic. And the temporary fillers really give us a chance to do things that what you see when you inject it are exactly what you get, which again is not necessarily true with the fat grafting.
That's actually the point that and that's fantastic the way you put that, because the predictability factor for the off-the-shelf fillers is probably, it's a lot more precise in my opinion.
I think so.
We can do really well with fat grafting. We do lots of it. However, the fact that there's only a percentage that takes, and it's hard if you're doing two different sides and you have a differential, and one side took 30%, one 50%, and now you have unevenness, that's not going to lead to quite as predictable results as something off the shelf that you put in a certain amount and that's what's going to stay. Whereas, with fat grafting too, you have to take it from somewhere. There's small risks of taking fat from somewhere.
Okay, great. One of my questions that was submitted and I hear about often in the office is, do you have any tricks on how to get rid of the blue or black patches underneath the skin?
The bruising.
The bruising.
Yes. So as we get older, the skin thins, the dermis thins, that's where our collagen and elastic fibers are, and the blood vessels in the skin become thinner and they're easier to rupture. And so we can get that purpura, that's what we call it medically, purpura on the arms, And there's really not much that can get rid of it quickly and kind of forever, but there are some things we can do. So the pulse dye laser that we use for redness, it's actually been shown that it can break up a bruise and make it go away faster. So if a patient did have purpura on their arms and maybe they had an event, a social event or something like that, then maybe it would be worth treating to remove that. And it's very, very quick to do that. But it's not going to be preventative. It's a treatment for when that bruise comes up to make it go away a little bit faster. Does that make sense?
Oh, yeah, that's interesting.
Yes.
A lot of the older people also have that purpura on the tops of their hands. And they also have thinning. And I believe there's fat transfers for that as well. Does that protect you from bruising? Or is that just a cosmetic outcome?
So the fillers, you can use fat, you can use hyaluronic acid filler, you can use a biostimulatory filler called Redness. They're FDA approved for volume loss in the hands. Probably the best option for what you're describing would maybe be Redness, which is a biostimulatory filler, because that works to stimulate your own collagen production. So that can maybe thicken the dermis or that second layer of skin and maybe help with some of that bruising.
Okay. Let's see. So, Dr. Casey, does insurance still cover breast lifts or reduction for back and neck pain?
So, short answer is yes, not for a breast lift. So breast lift and a breast reduction is the exact same operation. The only difference is when we finally take enough volume out, weight of breast tissue out, that we then call it a reduction. And there's actually a scale that we use. It's called the Schnur scale. Dr. Paul Schnur used to be the chair of plastic surgery here at Mayo Clinic in Arizona and had a very robust cosmetic practice. But that's based off of people's height and weight. It's a body surface area thing that there's a scale on how much we have to take out to be considered medically necessary. Now, most of the time, insurance has gotten a little bit more strict on you have to have neck pain, back pain, some bra strap grooving, for example, failed conservative means for 6 months. I don't know how conservative means can actually reduce that weight off of your neck and shoulders, but that's what insurance asks for as far as failing conservative means for usually 6 months. Every insurance company is a little bit different. Some of them do use different scales than I've ever even heard of, but the vast majority go by the Schnur scale, and if we can document that, then we do get it approved. I would say of the 4 I did just in the last week and a half, all of them were approved, and the one I have tomorrow is approved.
Okay.
So.
And do they start with their primary care doctor to document that, or do they start with the surgeon?
Either way. I have plenty of people that come in right off the streets that have either been wanting to have this forever. The normal response I get for the patients that are a little bit older is, I wish I would have done this sooner. The younger ones say, I'm so happy I did this now. And so
But they
you
would
can go either way with the primary care people looking first. It doesn't, as long as they can document that they have neck pain and shoulder pain, that they have tried either, whether insurance asks for chiropractic work, physical therapy, stretching, supportive garments, something, they can, that could be through me. I have plenty that I've documented it as the first person for that and gotten it approved.
So basically, they have to wait six months for the formal approval process.
That's the formal process in most cases.
Okay. Let's see. Okay, one of our patients said they recently lost 60 pounds and have loose sagging skin, underneath the arms. And they wonder if there's any, do you provide surfaces to address weight loss, skin laxity, associated skin
Do a
laxity?
lot of that, especially we've got a pretty robust bariatric surgery program here that, the keys on that, we don't want to have people actively losing weight still because they're what I call catabolic. They're breaking things down. They don't have the building blocks to be able to heal. If they've stayed at a plateau weight for a minimum of 6 months, usually a year, then I think they're usually excellent candidates for it. And we usually address the areas that they have the biggest concerns. And there are some times we can get insurance to cover it. It's tough. Their criteria have changed over the years too, but sometimes we can get the belly covered or the chest covered. It's hard to get any of the other covered by insurance, but those patients tend to do very well, and there's no weight loss technique, there's no no creams that they can put on that's really going to tighten that skin other than surgery, unfortunately. But as long as they're at a stable weight and they have the building blocks to heal and no other real issues as far as medically, then they do really well with this. Again, the arms, I'm not a huge fan just because those scars tend to be a little bit thicker. They're not as easy to hide. And they do, about 1 in 4 people get some numbness around the elbow, which can be, if you have a numb knee from a knee surgery, it's not a big deal, but every time you rest your elbows down and it's numb, people tend to find that a little bit annoying. But there's nothing else that can address that other than that surgery, and it's a pretty straightforward surgery to do.
So on to the facelift issue. So I know that Dr. Howard has been doing a lot of in-office facelifts. Why would you recommend that for one person versus the operating room setting for a facelift? What would your criteria be?
One of the big things for me is the individual's own desire. So some people really want to avoid a general anesthetic. People have had, stressful or traumatic experiences maybe with a past surgery. And I do think that state of mind and emotional feelings around these big cases plays a big role into how we handle healing and how we do heal afterwards. And so I really take that into consideration. And some people are very, very afraid of needles, for example. And so they have no interest in being awake. Because one of the big things is that if you're going to do a facelift or any procedure awake, is that you have to have numbing. And so you have to go through the injections, and that's not necessarily comfortable by any means. And if you're not asleep or partially asleep with an anesthesiologist, you do experience some of that discomfort. And so the biggest question is, what is right for the individual? The other one is that as our own medical complexity increases, I think it's very important that individuals have surgery in an OR with a board-certified anesthesiologist to watch them. For individuals who are otherwise healthy, this can be a wonderful opportunity to not have to go through a general anesthetic, in which case we do end up having fluids. Our body does have a little bit more of an inflammatory reaction with that, at least in my experience when I look at individuals and their swelling after surgery and their recovery after surgery. But it has to be the right thing for the person's own kind of belief systems, values, fears, and also their overall medical health. So I think it's a wonderful thing that we offer. It is not for everyone, but it is an opportunity for some.
Okay, so are you implying that the person is awake during this procedure?
They are awake. They're awake. So it's something where most people honestly take a nap. You have an anxiolytic, so a med that kind of makes you just not care so much. It's like a good margarita. And so once you're completely numb, you have no sensory feedback. We have quiet music going. And most people honestly take a nap. And so we end up with people that are snoring, quite frankly, which is how we know that they're asleep. Or, kind of shifting a little bit, and we keep everything quiet and peaceful and check in with them every once in a while of, how are you doing? And most people are taking a long nap.
How long is it in-office facelift?
It's an all-day event, rather similar to coming into surgery.
Okay.
It takes about 2 hours per side, so we generally get someone all numbed up, get them comfortable. We do one side. We kind of get them up, moving around. It's hard to sit in one place for that long. I can barely make it through a airplane flight for that long, and I don't expect someone to stay still on a clinic operating type space for that long either. So we get them up, move around, take a little bathroom break, come back, get the other side numbed up, go back to our sterile fields, and finish up the other side. So it's about 5 hours total with a break in the middle and 4 hours of operating time.
Okay. So many of our patients go to different plastic surgeons in the Valley, and they have a setup where they have a special overnight stay and different people to attend their needs. Do we have any of that at Mayo?
We don't currently have a separate place to house people overnight. We do have the opportunity to have them stay here, though, at Mayo. And we've worked that out at a very discounted rate for Mayo so that our cosmetic patients, if they need to, can stay overnight with our amazing, Mayo Clinic nurses, all of the usual care that we provide at Mayo Clinic. So it's one thing that for us is very reassuring, because if we have people that aren't quite comfortable going home, or aren't in the situation to go home, we know that they can be here with our phenomenal staff in the safest situation possible.
That's been particularly helpful for the out-of-town people because
Yes.
it gives us an opportunity to monitor them overnight, especially some of the bigger cases where you do worry that, we see a wide spectrum of patients here, different age ranges, different comorbidities, and we do tend to have some of the patients too that may not feel comfortable because of all their medical complexities having surgery elsewhere. So we do have the facilities here to be able to care for them. And I will say that our nursing staff here, in my opinion, is the best in the world. And I would support that and argue that till I was blue in the face.
There's some
I
data
second
to
that.
support that claim.
Yes.
For elective cosmetic surgery, are there any particular medical conditions that you would say you wouldn't feel comfortable operating on, from, let's say, from a facelift standpoint or breast surgery? And can you elaborate, is one have higher risk than the other?
For me, I think my die-hard one that I just don't think is safe is smoking. I will not consider doing an aesthetic procedure on someone who's still using tobacco or nicotine. And that's something where it really does change blood flow, it changes healing capabilities, and at the end of the day, also from an aesthetic or anti-aging perspective, the biggest thing that we could ever do is to treat the tobacco or smoking as opposed to any procedure. So that is the one that for me is a no-go up. There are many other things that are soft calls that we would like to avoid, such as significant anticoagulation and blood thinners. But every person's unique and individual, and so it's often a discussion, but for me it's smoking.
So what if I had a nicotine patch?
So I don't like the nicotine patch either. It still causes vascular changes, and I do believe that it changes healing. And thankfully, usually these are not emergent issues.
Right.
So we can always just take a little bit longer and make sure that we have any individual at the best point they possibly can be from a healing perspective, and then do an aesthetic procedure.
Those are my criteria, almost
Okay,
verbatim.
great.
And I think the biggest thing, they're coming in for something elective, and there's I tell every patient that I see that is a smoker, I say, I am not a public service announcement. What you do on your time, you're free to do, but please, I want you to end up with the result that you're looking for. We're not going to do an elective procedure, take the skin and move it on your face, and now have the skin die off and have a terrible problem. I just, for your own well-being, I don't want that for you. And it's just not worth it for them. And there's plenty of ways that we can work around that. I also don't like the nicotine patches, gums, any of that. I think Chantix or something along those lines are fine. And this doesn't have to be a lifelong commitment to not smoking. It's just the immediate period of before surgery to get all those chemicals out of your system, and for a period of time after surgery.
And that is, for me, I want 30 days without before, preferably 3 months, and 30 days at least after. I will actually do nicotine testing, not because I think anyone's not truthful or honest, but because very often if we've got tobacco use or nicotine in our lives, we also have that in our loved ones. And if secondhand exposures are high enough that you come up positive on that test, then it's also probably significant enough that it's affecting your healing. And so I will test that on individuals about 30 days in advance, just to make sure that we really are in the right place to do a procedure.
Okay, so we are a teaching center. Can you tell us a little bit about who will be participating in one's surgery? And that,
Yeah.
I'd like to answer that.
Well, in my world, I can't do the operations without resident physician help, because we need 4 pans of hands scrubbed. And this comes up periodically where the patient will say, and I'm sure everybody hears this, you're going to be doing the surgery right? And the answer, of course, will be yes. And if there's a surgical assistant who, rather than being a certified nurse or a physician assistant, is a resident physician, this is an excellent assistant, and they learn while they're helping you. And there's teaching that goes on, and so there's perhaps an extra focus to be perfect, or as perfect as possible, to demonstrate how this really should be done. So, in my view, it's a situation that makes for, if anything, a better operation.
And
Comments?
Anytime for example, during a facelift, it's impossible to do solo. And so we'll generally have either a resident that's assisting or one of our physician assistants who are wonderful. I will do all of the major moves, especially in aesthetics and cosmetic procedures. Will they be assisting 100%? That sometimes does also include doing things like throwing suture. I will check every single knot that goes down. It is ultimately on me that it is as good as it is from my hands that I could possibly do every single day. And I hold myself and every person that's in my OR to that standard.
And I can tell you that this team's reputation is extremely compulsive. They're all perfectionists. They're artists, honestly. And so, without a doubt, they're known for their perfectionism. So, I would trust them with that.
I think we have a lot of layers here. We have a medical school, so there's medical students that are learners. We have physician assistants that are with us, nurse practitioners. We have our OR staff that's with us. I think we function as a team. What I tell patients sometimes is when we start to deviate from our normal routine is when bigger things tend to have problems. When we get outside of our comfort zone, outside of our norms, problems start to occur when we're starting to do things differently. And we do have residents here. I'm the program director for our plastic surgery training program here. So I call it graduated levels of responsibility. The breast reductions I've done in the last 2 weeks, or a week or two, probably have an average of 800 sutures being placed at any given time during this operation. And our residents are putting some of those sutures in. And I'm there and I'm responsible for every one of them. But it's also because I've observed their capabilities from sometimes even during medical school as visiting residents coming or medical students coming with us, and watch them progress, starting with small things and progressing up through the ranks, because eventually we can't have trainees at a place go from 0 to 60 on a curve that's a straight uphill. It's got to gradually climb, and that's what they do. Ultimately, though, I'm responsible, and I'll also say that I'm never happy with any outcome that I've ever had. I have issues, but it's because I expect everything to be perfect, and I want it that way, and we make sure that we sit there with the residents, with the PAs, and I will tell you my PA staff here is exceptional, and some of them are probably better at some of this stuff than I am.
With rare exceptions, the plastic surgeon is much harder on themselves and on their outcomes than the patients are.
Okay. Well, that's nice to hear. So along the academic lines, I believe there was mention of opportunities for research and different clinical trials. Is that right? Mm-hmm. Do each of you have different active clinical trials or ones that are in the pipeline?
We've got some that are combined that will involve all of us that are in the pipeline, and then we all have active research that we're each involved in. And it has a tendency to reflect, I think, our own areas of interest. So mine has a lot to do with complex nasal reconstruction right now, where we are enrolling patients and going through 3D scanning, printing, modeling, not only to improve their surgical outcome, but to improve our communication with individuals about if they're going through large nasal resections for cancer, what exactly reconstruction would look like, what did the problems they have look like. And so that, I know, is my little active clinical trial and microsphere that I live in. And each of us have areas that we are actively doing research, not only as a group, but solo.
We do, and it ranges everything from, I have a small project looking at using a vein finder, which is a near-infrared technology to look for surface veins when we're doing Botox to see what our outcomes are as far as swelling, bruising, things like that, to bigger things such as some of the breast reductions and migraines and their association and links, postoperative outcomes. But we are an academic institution, and that's one of the three shields, so that's something that I think we're all passionate about and what's somewhat expected of us.
And that's Mayo has a self-goal, as it were, to be the #1 destination for regenerative medicine in the next 10 years. And they are looking at the aesthetics group, at our anti-aging group, to be one of the big leaders in that. Because this, as you kind of saw from that, how Mayo defines regenerative medicine, that is something that this group will move forward significantly.
So is that enveloping the stem cell work? Is that what you're talking about?
All of it, all of it. So everything from the platelet-rich plasma to clinical trials on new drugs and new products to stem cells to laser therapies that actually kind of reset our skin and genes backwards. And, you know, the real exciting stuff, the things that we haven't even thought about yet.
And if you look at some of the things even that their group's doing with Dr. Lott's regenerative medicine and making tracheas, if you look at the breast reconstruction we're doing called deep infrared epigastric perforator flaps, which is a very invasive procedure. It's a great operation, but involves moving tissue from the belly up to the breasts and hooking up blood vessels under the microscope. I think the future is not that. I think the future is regenerative medicine. It's taking somebody's stem cells and dropping it in a test tube and starting to grow it and adding the growth factors that it needs, and now you can build a breast and then add that, rather than the donor side of taking a big scar on their belly and the recovery of that. That's the future.
I wonder if any of you have a special case that you'd like to share that really you're most proud of. And I'm kind of partial to, you know, cancer cases where somebody has been somewhat disfigured from the required surgery, and perhaps you've then been able to make them whole. Are there any cases that?
We have one case that all three of us have shared in, certainly. We have a flight attendant, and her story is very searchable right now on the web or on Mayo. I think it was picked up by UK Daily Mail. And she lost a very significant portion of her nose to a recurrent basal cell skin cancer. And so myself and my team did the rebuild of her nose. So she went through about 5 surgeries in which we actually took her forehead and brought that down to her nose to rebuild the inside, the outside, and then you use rib cartilage to rebuild the shape. Dr. Casey continues to work with her on removing the hair that my surgery transplanted to her nose, so that she actually, the shape that I built looks as good as it should, and he's done a beautiful job. And Dr. Haas has worked extensively with her with lasers to remove pigmentation changes, to blend out scars, to make them nearly invisible. And so I think that's one of the great cases we've all done together and worked together on.
So I'm kind of curious. I'm surprised that you're working on the hair part. So
Removal.
Right.
Remove.
I know you're probably doing hair growth, but you're removing hair. So, because I usually think of you as doing facelifts, breast surgery.
As I said, what doesn't plastic surgery do?
This is so true.
How do you do that?
With the laser.
Oh, okay.
Actually, the laser we have for that's a really good one. It's a little bit older, but it's very
Okay.
effective. Laser for hair removal, the standard, the most common is if it's dark hair with light skin, because most of those are targeting the darker pigment in there, trying to get rid of the hair follicle at the base.
So if they have gray hair, it's tough.
It's tough.
There's other ways to do that, though.
Okay. And then actually, I don't want to forget to ask the question. Many of our patients are concerned about hair loss, and wondered if Dr. Haas has any suggestions on how to, if not promote hair growth, but at least maintain the hair we have.
I'm all ears.
Yeah, Dr. Hinney is.
Yes, I think maintenance is the most important thing that you mentioned. Hair loss is really difficult. You know, it happens to all of us. It's happening to men. It's happening to women. While women don't necessarily lose all of their hair, they do significantly thin with age, with potentially up to 50% of women having hair loss by the age of 70. So that female pattern hair loss. So it's very, very common. And there's a lot of things we can do. You know, Rogaine is over the counter. That's kind of tried and true, but difficult for a woman to use. They've actually done a study recently from the Mayo Clinic in Florida where they compared Rogaine to platelet-rich plasma or PRP injections, and both were effective. The patients in both groups saw improvement, and they actually had them kind of cross over. And the patients found that they preferred PRP. This was a study in females. They preferred it because it was more convenient. It was potentially only once a month or every 3 months, while putting Rogaine on their scalp every single day for a woman, you know, the three of us here can attest to that sticky feeling, the changes to the scalp or the hair when you're trying to blow dry it or style it. And since both were effective, you know, a lot of patients thought that PRP would be a better long-term outcome or option for them. So I think that's something that we're doing a lot more of for hair loss.
So is that something you have to do forever, as long as you want to have hair? Is that a commitment for life?
Yes, right now we think that it's, you know, something that you continue to do. Just like how we continue to color our hair or get Botox every 3 or 4 months or keep our gym membership to stay, you know, fit. This is kind of something we'd have to keep doing to maintain.
And so if I wanted to make an appointment for something like that or something else that required periodic upkeep, do you book all the appointments for the year, or how does that usually work?
Yes.
Just so you don't fall off the radar. And
So my nursing team and cosmetic schedulers do a great job of scheduling the appointments as far in advance as they can. So if it's PRP once a month, they'll book them all if the patient has their schedule. If it's Botox every 3 or 4 months and the calendar is not open yet, they will set a reminder halfway in between to call the patient as soon as that calendar opens so they can get in for their kind of subsequent visits throughout the year. So they don't call, you know, 3 or 4 months later and the whole schedule is booked. So we kind of have everybody on a schedule for follow-ups, which has worked out great over the past year or two.
well, I want to thank everyone for your time. This was really, we're very grateful for you coming in and sharing some of your information. And I want to thank everyone from the Medallion program that attended tonight for your time, your participation, and wish you a good evening.
Thank you so
Thanks
much
so
for
much for having
us.
us.
Thank you.